Thank you very much, Kamal, for inviting me for this very prestigious and informative conference. Thanks a lot. And Kamal is always in the front of this delivering academic conferences and lectures. And I basically look upon him as a very academic professor in cardiology because he's also a professor in UN Mehta. Anyway, so my talk is on FFR in intermediate coronary stenosis. So this is about the patient. He's 55 years old and he's a bus driver. So he's leading his active life, and he underwent angioplasty to LAD, which was implanted 9 months back. Currently, he's having angina. Troponin is normal. eGFR is 44. So it's CKD stage 3. His TMT is borderline positive, and his angiography shows an intermediate stenosis in LAD stent. Now, how to proceed? It's very important to know what exactly this stenosis is significant or not, because we have to treat him. Of course, medical treatment is there, but whether he will require any intervention, that is the prime question here. So two fundamental questions here. Is the lesion significant or not? Just hold on 1 minute. Yeah. So is the lesion significant or not? That is, we have to decide, because it's an intermediate lesion. And we know that angiography may be dicey here, may not show the perfect severity of the lesions. So is the lesion significant? It is producing ischemia. That is the first fundamental question. And has the PCI been optimized? Because if you do not optimize the PCI, it will not matter even if you offer a stent or not. That is very, very important. These are the two fundamental questions we have to always answer. Why it is important to know this patient is having ischemic lesion or he is really having ischemia? Because we know by the studies that any kind of ischemia burden will increase the MACE rate. So it's very, very important to know whether this patient is suffering from ischemic coronary artery disease or whether that particular lesion is ischemic or not. At the same time, we don't want to put stents, because if we just put stents depending upon the angiography lesions, putting unnecessary stents definitely increases target lesion failure. It increases the cost. There are so many. There are about 5% chances of developing in-stent restenosis repeat procedures. So there are problems of putting unnecessary stent apart from the cost. And this slide shows about it. Also, we know that stenting may not benefit every patient. We have ischemia trial where we know that stable ischemic heart disease and moderate to severe ischemia on stress testing, we can, in fact, the OMT was almost fair equal as compared to intervention. So this was the ischemia trial. So how to evaluate this patient who's having intermediate stenosis? Visual, by just looking at the angiography, or we do a test called physiology. We put a pressure wire in the coronary arteries and decide whether the lesion is significant, or we do imaging. We look into the artery. We visualize the artery from inside and see whether there is any plaque or how much is the minimal lumen area. So these are the three modalities. Of course, we all know that just looking at the angiography visually, it's a two-dimensional view, and it always varies from which view you are seeing, and it sometimes cannot give a clear view of the severity of the coronary stenosis. So, of course, there's observer bias in coronary angiography, seeing visually. What about imaging? Now, imaging, the most important thing we see in imaging is the minimal lumen area. Now, the studies have shown that just observing minimal lumen area is having a very high negative predictive value, but a very low positive predictive value. Now, as a clinician, we are always worrying about, we always see what is the, for the patient benefit, we always see what is the negative predictive value and what is the positive predictive value. So what does that mean that is having a low negative predictive value, positive predictive value? Is that when the minimal lumen area is large, it's safe to defer intervention. But if it is small, it may not justify intervention. So it's like that. If the minimal lumen area of a non-LM lesion is more than 4 mm, it is safe to justify that, okay, we can avoid intervention. But if it is small, that because of the low positive predictive value, it may not justify intervention. And plus, the IVUS will not tell you what is the amount of subtended myocardium, how large is the myocardium below this coronary arteries. So these are the problems with imaging. And then there was a meta-analysis which was done in Korean, which was published in Korean Circulation Journal, and the conclusion was that the IVUS-derived minimal lumen area has a limited diagnostic accuracy, and it needs a careful interpretation to correlate with functionally significant non-LM stenosis. So these are the problems of the imaging. Now coming back to the physiology, what is pressure wire study? So in the pressure wire, what we exactly detect is the blood flow distal to obstruction, or which is compared to a blood flow without the obstruction. And we cannot measure directly blood flow because it's difficult. So what we do is, as a surrogate marker, is measuring the pressure. So what is the pressure beyond the artery, and what was the pressure in the presence of a normal artery without any obstruction? So it's just like FFR is measuring, it's almost like a surrogate of a treadmill which is done inside the cath lab. It's a stress test for the artery inside the cath lab during the cath. So this is about the, which I'll come to the future trial. This is about the pyramid of diagnostic accuracy. If we just do a coronary angiography, it is only positive. It's correct only 65% of times. 35% of times it may be erratic. And FFR is almost 95% of times you are certain that this patient is having a physiological significant stenosis. And these were the initial landmark trials which came out of physiology, the FFR. One was the deferred trial, where, as the name indicates, if the FFR is more than 0.75, so it was compared between PCI and medical. So what this trial meant was, can we defer the PCI in the patients who have FFR more than 0.75? Then came the FAME trial, which actually ruled in PCI in the patients who had FFR less than 0.8. So it was a comparison between FFR less than 0.8 versus FFR more than 0.8, and FFR 0.8 was less than 0.8 was actually subjected to PCI, while the rest was subjected to medical. And then came the FAME2, in which they compare in the patients who had FFR less than 0.8 and they were offered PCI with medical therapy or a medical therapy alone, and then it was compared which fared better. So in the deferred trial, it was proven actually that the patients who had FFR more than 0.75 and if we deferred interventions, they actually fared better. So the cardiac death and acute MI were actually much better as compared to the patients who underwent an intervention if the FFR was 0.75. So this trial proved that, okay, if the FFR is more than 0.75, we can safely defer intervention. So that is about this trial. And then came the trial of FAME study, which actually proved that if the FFR is less than 0.8, it is better to intervene this patient rather than putting on the medical therapy alone. And death and MI after 2 years actually fared better in the patients who were offered interventions if the FFR was less than 0.8. While in the FAME2, it was actually compared between ischemia directed PCI plus OMT versus OMT alone. Means the patients who had FFR less than 0.8, whether to offer PCI plus OMT or OMT alone. And again, in this, it was proven that the patients who were offered PCI plus OMT in FFR less than 0.8, the cumulative incidence of MI, death, and was actually much better in these patients who were offered PCI based on FFR. So one thing was certain, that beyond 0.75 or 0.80, intervention is not required. And if the FFR is less than 0.8, interventions may benefit, reduce the future revascularization. Of course, mortality may or may not benefit, but definitely it reduces the future spontaneous MI, spontaneous revascularization. So this was the essence of these trials, namely the deferred trial, FAME1, FAME trial, and FAME2 trial. And it was proven that routine adoption of FFR in clinical practice allows the physician to make right decision for the right patient at the right time. Now, the greatest advantage, as I told in my before slide, was that we are avoiding actually stents. Stents means cost. So there was definitely proven cost effectiveness by using physiology studies, and it was economically better, especially in countries like in our countries like India, where stents may cost some money. So definitely it is cost effective, and we are avoiding contrast usage also. There are many benefits of not doing the procedure, like contrast usage involved during the procedure, especially in this kind of patient where it's a CKD stage 3, eGFR is 44. If we avoid intervention by proving that FFR is more than 0.80, we can reduce the contrast usage, and we can reduce the contrast-induced nephropathy or contrast problems, which may deteriorate the kidney functions. So it saves resources, it increases the quality of life, it improves outcomes. Outcomes have been, all the trials have proven outcomes with FFR, and of course, it is very cost effective, and it reduces the cost. One more thing is that it changes the perception, it changes the treatment also depending upon the FFR. Like it was a trial was compared between angiography based severity, angiography based number of coronary vessels involved, and once they did an angiography, so there was almost a 30 to 40% change in the management of the patient. Like three vessel angiography on three vessel disease on coronary angiography was actually proved only 14% with physiology, and 2% was actually proven with only 43% with physiology. So if we use physiology in all the patients randomly, and if who have been multivessel disease, and if we do a physiology, at least 30 to 40%, the management will change, which means they may or may not require interventions in that particular vessels who were judged significant or non-significant on coronary angiography. So this was about all the trials, and recently a very large trial, very famous trial came called as FLAVOR trial, in which the physiology was compared with IVUS, and it was proven that physiology-based studies or physiology assessment is non-inferior to IVUS. Well, we all know that it's almost non-inferior to IVUS, but we know that the IVUS comes with cost, or any imaging comes with cost. While in FFR, the advantages were that there was no cost of imaging involved, there were less number of stents involved, there's less number of cost involved. So these were the advantages, and plus it was non-inferior to imaging studies. So that is the greatest benefit of physiology, which I think is much better as compared to imagings. And this was a landmark trial, the FLAVOR trial, which was published in NEGM. Then there was one more trial called as FFR trial, in which the physiology was compared between OCTs, and this came in JAK interventions. Of course, in this trial, the physiology was compared between, just a minute. Okay, of course, in this trial, the physiology was compared between OCTs, and it was proven that, again, the physiology, there were more patients put on medical therapy as compared to interventions, again, reducing the cost, reducing the extra number of stents used, reducing the length of the stents used, and reducing the kidney injury because less contrast, reducing the cost. There were more PCIs in the OCT groups, more increase in contrast medium use. Of course, there was decrease in MACE and significant angina with PCI because you offer more stents, but the cost, the kidney injuries and medical therapies were definitely much better with physiology studies. And this was again in the same trial where the patients who were managed with medical therapy were much higher in physiology studies, and the costs were much reduced as compared to the OCTs in the FFR trial. This came in JAMA, and this proved that it is not dichomatous, like if we make the FFR 0.82 or 0.81 after the procedure, the patient will fare better. The more, what I mean is that more the increase in FFR, more better the outcomes. So it is a continuous variable, and it has been proven that post PCI FFR of at least 0.95 is the target we should achieve in achieving an optimized PCI. So even with because the pros of imaging is the people who actually are pro imaging, they always say that the optimization of PCI is much better with imagings. But in fact, even with a physiology study, if you prove that the post PCI FFR or imaging is at least 0.9, post PCI FFR is at least 0.95, that indicates that the PCI is optimized, the stent is optimized, and there are very low chances of future events. And this was actually studied in the JAMA, where actually they studied the post PCI FFR, and they found that it was a continuous variable, and the higher the FFR after post PCI, more better reduction in the events. And in fact, it has been given a class 1 indications in the ACC guidelines. It has been given class 1 indications in European guidelines. So to conclude, physiology guidance will help you in appropriate need for stents, avoiding stents if it is not necessary, and having given you objective evidence of ischemic, whether this particular artery is ischemic or not. Like if you do a treadmill test, treadmill will not give you an exact idea which vessel is ischemic and what level it is ischemic, while physiology will give you which vessel, what level is ischemic, and it will give you objective evidence of ischemia. It eliminates operator uncertainty. As I told, the decision changed when the people did a physiology versus angiography alone. So minimal observer bias, it's guideline recommended. It's used for optimizing of revascularization strategies, even post PCR strategies, even stent optimization can be done with physiology based, and very important. It is very cost effective and it improves the outcomes which have been proven in the trials. Thank you very much.
Thank you, Vineet sir, for the introduction to our session. As rightly said, we are now into a phase where we keep on discussing how we are going to deal with, and we forget the basic question whether actually the patient requires, rather than going ahead and planning things. So, I'm Dr. Priyank Modi, and I would be speaking on IVUS. Good is good, bad is bad. What is not white shall be black. It's a quote I just wrote an hour before. So 5 millimeter LMCS stenosis, we all know IVUS is the choice. A borderline lesion, FFR is the choice. Early restenosis in a mid LAD stent of 3 millimeter OCT gives you maximum information to determine the mechanism of restenosis. The problem is life isn't black and white, black or white. It's all sorts of shades of grey in between. I think that is the reason Dr. Kamal Sharma brings Cardiocon every year to discuss these grey zones of cardiology, where learning can be a two-way process, not just speaking for something, but getting the other side and changing the way we practice. So what do we have today? He's a 54-year-old guy. He's a bus driver. He has had in-stent restenosis, a restenosis which has happened in the first year of stent implantation. It's an osteal LAD lesion. The patient is symptomatic. Borderline markers, the top slightly positive, stress test inconclusive, and an established reduced renal function. Now, what do we have and how do I see it? So he's a 54-year-old guy. I see him as a young person who deserves to get a single one-time lifelong procedure. He's a bus driver. It's a responsible job. Any event in him, whether it is an acute coronary event or an arrhythmia, is not just going to endanger his life, but it is going to endanger life of thousands of people who may be traveling in his bus over a period of time. In-stent restenosis. Here the in-stent restenosis has happened in a large stent. It's a 4 millimeter stent, and we have a stent restenosis in less than 1 year. It's very important to understand the mechanism of restenosis if we plan to intervene. It's an osteal LAD lesion. We need to make sure that the result is optimum. Osteal LAD are the widow makers, and any problem there can be life-threatening to the patient. Is symptomatic and there are borderline markers. Here I would err on the side of safety. He has reduced renal function, so we have to make sure that we don't harm the kidney in anything we do. So the very first question, whether the patient requires intervention. Dr. Vineet sir has rightly put up, any physiological assessment would be the first way forward. So what's my take here? He's a young guy and has osteal LAD disease. We have to understand here, it's not a native vessel disease. He has a stent implanted just 7-8 months before, and he has progressive disease in the next 7-8 months. So if we leave the disease at this point of time, I'm not talking about another stent implantation. I'm talking maybe about optimizing the previous result. But this is a progressive disease. In 7-8 months, it has progressed to 70%, and it is going to progress further. Very sure the patient is on medication. He's a bus driver, so it's not only his life which is at stake, but many people who travel with him. So here, personally, I would err on the side of intervention. He is young, a job profile which involves multiple lives, and an early ISR. So re-intervention, if at all we plan, irrespective of the discussion here, has to be imaging guided. So why did I select high definition IVUS as the preferred modality. So my reasons for selecting IVUS, it's an early ISR. We need to understand the mechanism of restenosis. Imaging is a must. OCT, though a better modality in giving a good image quality, but HD IVUS fares pretty well. It's an Osteal LAD lesion. 4 millimeter stent has already been implanted. We need to see even the sub-stent anatomy. So good penetration is a must. Patient has reduced renal function. I don't want to increase the dye load. Rather here I would want to err on zero contrast angioplasty if at all it's required. So my mama taught me our prime purpose in life is to help others, and if we can't help them, at least we should do no harm. The most important for me is the borderline renal function eGFR of 44, and these patients are prone to get into an acute kidney injury. So PCI patients with underlying chronic kidney disease and diabetes mellitus, they have a high risk of contrast-induced acute kidney injury. eGFR of less than 60 is a strong risk factor for contrast-induced AKI, particularly like an intra-arterial contrast administration, what we do for angiography or angioplasty. According to the Mayo Registry, 3.3% of the total patient who went for PCI developed AKI, and considering that this patient has borderline markers in acute coronary infarction, the chances of developing AKI in this particular patient would exceed 20%. If you see the data, the mortality rates at 1 month and 1 year were significantly higher. An incremental use of 75 ml of contrast would increase the risk of AKI by 42%. The maximum considering the GFR of this patient would be 100 to 120 ml of dye what we are going to use. And we all know that Osteal LAD lesions are the lesions in real life practice where we require maximum dye because we really want to place the exact stent. Maybe left main to LAD crossover would require far lesser dye. So reduction in contrast volume by just 30% would prevent AKI incidence by 13. I think Dr. Zayed Ali was one of the initial people who had a paper published on zero contrast angiography or angioplasty. Our Indian data comes from Dr. Pratap Kumar. So he did a study in the 6 months between November 2019 to May 2020, where he included 15 patients. And why did I decide to select this study? To quote my point. So PCIs in patients with significant renal dysfunction is a challenging because the risk of AKI is there. With advancement of IVUS, we can go towards zero contrast angioplasty. So he selected around 15 patients, and coronary angiogram was routinely done with minimum dye. For angioplasty, guide catheter we can all engage the guide catheter based on our experience. How will we know that the guide catheter is engaged? Based on the angiographic views, we can give a short normal saline injection that would cause some ECG changes, which would be transient, and we'll know that we have engaged. We can pass in the wire. If the wire goes into the conventional routes where the coronaries are, we know that we are engaged. Generally, now integrated IVUS system would give us a very clear idea how the lesion is, where we have the normal segments, what will be the size of stents. Post stenting, we can optimize the stents based on IVUS, and practically the use of contrast would be near to zero, or maybe only in emergency or to take the final shoot. So 15 patients were there. eGFR of the study substrate was around 31, and 4 patients of these 4 patients here in these 15 patients were left main coronary artery patients, like in our patient. So that is as much as 25% of the patient substrate had bad disease. These were not type A lesions, and in spite of that, zero contrast angioplasty was possible. High procedural success was achieved without complications, no major adverse event, not even one patient required dialysis. So zero contrast PCI guided by IVUS is a very safe thing to do in coronary artery disease, particularly in patients with moderate to severe CKD. What does the guidelines say? For non-LMCA lesions, IVUS and OCT or imaging is still a class 2B indication. What is the data of use of IVUS in in-stent restenosis? RIPS-3 study was the first to evaluate. Here, no significant benefit was found, particularly because only around 40% of the patients had IVUS use during the procedure in in-stent restenosis, and the use of IVUS was put on the operator's discretion. IOPEN ISR registry was the first, it was around 300 patients or so, which demonstrated prognostic benefit of use of IVUS in ISR cases. What does the guideline say? IVUS is superior to OCT, that is the 2018 ESC guidelines for LMC and Osteal disease. As Vinit sir rightly said, MLA of LMCA less than 6 correlates with an FFR less than 0.75, and these were the patients whom intervention could be planned. For Osteal LAD, we do not have exact data like 4.8 for Osteal LAD for Asians. Indian data still lacking. I believe Dr. Kirti Poonami and a lot of other people are gathering data of Indian patients on IVUS, so maybe over the period of time we can have our own numbers. So there was a correlation between IVUS and FFR, and MLA of more than 6 correlated well with an FFR of more than 0.8, and here we could easily defer revascularization. So the step 2 in this particular patient, the first step why I wanted to use IVUS was to make sure that we do not have to use dye. The step 2 important aspect here is it's a 70% lesion. Post wiring, we can directly take an IVUS run without any pre-dilatation. This would give us an opportunity to identify the mechanism of restenosis. Stent under expansion. I believe this might be the most common reason, because it was a 4 millimeter stent and the ISR is less than 1 year of age. So stent under expansion remains the most common reason for ISR around the world, and imaging as modality is the gold standard to make sure that we have stented it right. Missed ostium in that case can be identified if at all the LAD ostium was missed, and that is where the restenosis has happened. If there was a stent fracture, particularly during post dilatation of the previous procedure, can be identified. If the ISR is happening on the distal part of the stent, then an edge dissection and increased plaque at stent edge can be identified with an IVUS, and that may help us to identify the mechanism of restenosis. Once we understand the mechanism of restenosis, it would be extremely wise of how to go ahead with the procedure. So these are different IVUS and OCT views for stent under expansion, or thrombus, stent missing the thing, a dissection flap, a fractured stent, and anyone of us who are using imaging on a daily basis, this would be a routine thing to identify. IVUS would just not let us understand the mechanism of restenosis, it would even help us plan the treatment. As Vinit sir rightly said, and it would be very wise not to put up extra metal or extra stents in an already stented segment. So understanding the mechanism would in a clear way help us how to go ahead. If there was stent under expansion, the simple way forward based on the IVUS imaging measurements was to expand the stent with a new NC balloon, a larger NC balloon. IVUS also would give us a very good idea about the plaque or neo-intimal characteristic. And here HD IVUS would be better than the routine IVUS, the 60 Hz catheter we have. So over the period of time, it has been determined in different studies. The original study was through Lee and all. So homogeneous versus heterogeneous plaque, like a fatty plaque which is more homogeneous, fared better with just drug eluting balloon, and we could avoid stents, and 1 year target vessel revascularization was far less. If the plaque was heterogeneous, then maybe another drug eluting stent would be a better choice. So IVUS would just not help us determine whether the patient requires intervention, but if we take it forward through the MLAs that the patient requires intervention, it would help us know why the in-stent restenosis happened, and to optimize the result of this in-stent restenosis.
Yeah, please wind up. Yeah,
sure,
sorry.
Sure. So that is the summary of why we would go ahead with IVUS in this particular patient. Maybe in the discussion part, we would have the differential between OCT, IVUS, and FFR in this particular subset. Thank you so much, sir.
Hi, my name is Mamas Onmas. I'm Professor of Cardiology at Keele University, the United Kingdom. It's a real pleasure to join Cardiacon, and I'd like to thank my good friend, Dr. Kamal Sharma, for inviting me to contribute. I'd also like to thank the other discussants for what promises to be a very interesting session, to both Dr. Modi and Dr. Sankler. So this is something that's very close to my heart, both physiology and imaging. And really, our discussion is going to be which of the three modalities is best for this particular case. Now, the important thing to say in this debate is, of course, we're doing this from an academic perspective. Often one uses more than one modality in many cases. So I think there is an important role for physiology and imaging. But nevertheless, my remit today will be to try to persuade you that OCT is the preferred modality. So this is the clinical scenario. This is a 55-year-old male with new onset angina and in-stent restenosis, which is assessed to be around 70% in the Osteal LAD, where he had a previous stent of 4/28. He has mild renal dysfunction with an eGFR of 44 mils per minute per meter squared and has a high normal, high sensitivity troponin. And we're given three choices in this gentleman's management: a pressure wire, an IVUS, OCT, but of course there's the fourth choice of using nothing. So I think these are the important considerations for this debate. This patient has had stent failure after 9 months. So really, we've probably got one more chance to get it right. So we should use everything in our armamentarium to make sure that this patient gets the best treatments. And I would hope that anyone approaching this case would ask 5 questions. And these are the 5 questions I'm going to take you through to show and try to argue my case that OCT would be better. The first case would be, should we be intervening in this case? The second question that we should ask when faced with such a case is, what is the extent of the disease? Would the patient be better served by a bypass operation? The third question that you should always answer in these sorts of cases is, what is the mechanism of in-stent restenosis? If we do decide to intervene, the fourth question should be whether we use a drug-eluting balloon or a further stent. And the final question that we should ask of ourselves in such a case is whether the result that we could produce is optimal. So, the first question, should we be intervening? And this is really the only question and the only part of the procedure that the pressure wire can answer and should be used. So in such a case, by all means, use a pressure wire, use non-invasive imaging to see whether the lesion is functionally significant. This is the only role for the pressure wire in such a case. The pressure wire cannot tell us the extent of the disease, whether the patient will be better served with cabbage. It cannot tell us anything about the mechanism of in-stent restenosis. It can provide no insight into drug-eluting stent versus further stent, and it provides only minimal insight into whether the result is optimized. So in my view, the pressure wire has an important role to answer the first question. Thereafter, it has little or no role. So then we're left between IVUS and OCT. The second question we should be asking ourselves is, what is the extent of the disease? Would the patient be better served with a bypass operation? Well, this is an important question. We know that patients undergoing PCI for osteal lesions have poorer outcomes. This is data from the Melbourne Interventional Group, which looked at over 1,600 lesions, 100 of which were osteal lesions. And you can see on the right-hand side of the graph that there is worse outcomes associated with osteal lesions. So MACE rates of close to 20% at 1 year compared to half the MACE rate in non-osteal lesions, so around 10%. And you can see there is a strong trend towards worse outcomes for each of the components of MACE at 12 months, particularly target vessel revascularization almost double. And as we've said, MACE double at 12 months, 25%. So these are high risk lesions. Now, one of the reasons that we want to image is to look at the extent of the disease. This is an osteal LAD lesion, and often we see in clinical practice, and I'm sure many of the proponents of this debate will have encountered this situation where you see an osteal lesion, you want to nail the ostium, you do imaging, whether it be IVUS or OCT, and you find left main involvement. Now, this is some data from my good friend Gary Mintz and colleagues. And what you can see is that isolated LAD disease is incredibly rare, 3% of cases. So the likelihood is this patient has disease in the left main, and we are going to have to stent into the left main. You can detect this, whether it be IVUS or with OCT. You would not see this with pressure wire. The next thing is, when we do something in interventional cardiology, we want to show that you have an improvement in outcomes. So, for in-stent restenosis, has pressure wire ever been shown to improve outcomes? No. In contrast, intravascular imaging, whether it be IVUS, whether it be OCT, has been shown to improve outcomes. This is some data published from the UK, from my group, looking at outcomes with complex PCI. As you can see, rather surprisingly, in the United Kingdom, only a third of in-stent restenosis cases have intravascular imaging. But you can see that for MACE, there is a reduction in in-stent restenosis of the odds by about 20 to 30% associated with intravascular imaging use, and the trend towards improved mortality as well, which was not significant. So certainly using imaging, whether IVUS or OCT, is associated with better outcomes in such cases. The third question, which I think is really quite central to this debate, is what is the mechanism of in-stent restenosis? Because once we understand the mechanism, that is when we can intervene and direct our approach depending on what the mechanism is. And this is really where OCT comes out on top. So stent under expansion is an important mechanism of in-stent restenosis. And you can see stent under expansion whether you use OCT or IVUS. Now, there are many reasons why a stent may be underexpanded. Perhaps the operator did not assess the size of the vessel optimally and put an undersized stent. That is a possibility. However, more important causes of stent underexpansion are things like calcification. And this is where really OCT comes out on top, because you cannot assess the thickness and distribution of the calcium as well with IVUS as you can with OCT. And clearly, your approach will completely differ depending on the nature of the calcium, which you can only assess properly using OCT. Other causes of in-stent restenosis that you may be able to identify is landing your stent in significant plaque. And I would say that probably OCT has an advantage here, but IVUS again is useful. Overlapping stents, so where people have used multiple stents, they've not overlapped, and there's been a geographical miss. That is another cause of in-stent restenosis that one has to address, and you can see that as easily on IVUS and OCT. Things like dissection in index procedure, you will see that on OCT, you may not necessarily see that on IVUS, and fractured stent, again, much better visualized on OCT than IVUS. So going back to the calcification, I think this is really quite key. When you're looking at underexpansion as your mechanism, you have to think about why have you had an underexpanded stent? Is it because that the operator has misjudged the size of the stent, or is it because of severe calcification? So this is the exact same lesion assessed with IVUS and with OCT. So it's a calcific lesion, and you can clearly see that both of them show calcification. With IVUS, you cannot tell how thick this calcium is. There's no way. So you cannot tell whether you can use a cutting balloon here. You cannot tell whether the calcium would crack with a non-compliant balloon. With OCT, you can see exactly distribution and measure the thickness of the calcium. Now you may ask me, okay, why do I need to measure the thickness of the calcium? Well, it's important to be able to measure the thickness of the calcium because that will tell you whether you will get good expansion. And we have scoring systems. So this is one such scoring system based on OCT. And you can see that if you have a calcium thickness of greater than 0.5 millimeters, then that gives you a point. If you have 4 points, then we know that expansion is going to be a problem. And you can think about the optimal way of managing this calcium, whether it be lithotripsy, cutting balloon, even rotablation. So I think it's really important that in cases where you have significant calcification, which is likely to be the case here in a patient with renal dysfunction, that you use OCT to properly assess the calcium burden, which you cannot do with IVUS. Now, the fourth part of the question is, okay, so we've assessed the mechanism, we're going to try to treat it. What should we use? Should we use drug-eluting balloon or a further stent? Now, obviously, If you only have one stent, as in this case, then you have that option. If you've had 2 or 3 layers, then you clearly cannot put another stent, and so you have drug-eluting balloon as your option. But in this case, we have the option of a drug-eluting balloon or a further stent. And this is a consensus document about treatment of in-stent restenosis using IVUS or OCT. And you can see, depending on the mechanism, will depend on whether you use a drug-eluting balloon or a stent. So if you have stent under expansion because the operator has misassessed the size of the stent, then I think it would be reasonable to use a drug-eluting balloon with perhaps a cutting balloon. If you have non-overlapping stents as your cause, then clearly another stent would be appropriate. If you have a stent fracture, then I think it would be reasonable to look at the design of the stent, and if it's one of the older, less flexible stents, then using a more contemporary stent with fewer links that allows for conformability would reduce the risk of stent fracture. Now, this is where OCT is key. If you have neoarthrosclerosis, you cannot assess this properly with IVUS. You have to have OCT. Now, depending on the type of neoarthrosclerosis will very much guide whether you use drug-eluting balloon or a further stent. So if you have a very homogeneous picture of neoarthrosclerosis that you can assess with OCT, but you can't with IVUS, then a drug-coated balloon has been shown to have as good and maybe even better outcomes than a stent. In contrast, if you have heterogeneous, layered or lipid-rich neoarthrosclerosis and neointimal morphology, then I think very much the view of the community is that you should be using a drug-eluting stent. So assessing neointima, if it's heterogeneous, layered, or lipid-rich, use drug-eluting stent. If it's homogeneous in appearance, then I think drug-coated balloon is better. You cannot do this with IVUS. And again, when looking at calcium, you can assess the thickness of the calcium, and that will help guide your treatments, whereas with IVUS you can't do that. It will only tell you the distribution of calcium, not the thickness. And this is quite a useful guide for intravascular imaging in guiding in-stent restenosis and stent thrombosis from my good friend Chris Bountis. And you can see that for many things, stent under expansion, malapose stents, looking at plaque at the stent edge, IVUS and OCT perform very similarly. However, for things like neointimal morphology, you cannot use the IVUS to assess this. And this is really important when you have neointimal hyperplasia, when deciding whether you use drug-eluting balloon or a stent. And again, if you want to assess for neoarthrosclerosis, very poor with IVUS. If you want to assess stent fracture or multiple stent layers, again, much better with OCT than IVUS. And the final question when undertaking these cases, so when you've undertaken the intervention, is whether your result is optimized. And we have guidelines. We have guidelines in that you should not land your stent in a plaque burden of greater than 50%. You should make sure there's no dissection at the edge of your stent, so not going into the media, less than 60-degree flap, less than 2 millimeters in length. We have MSAs that we aim for, and we have malapposition. So in terms of MSA, malapposition, you can equally see these on IVUS or OCT. For dissections, much better on OCT. Many watching this debate will have experience on IVUS. You sometimes cannot see dissections very well, particularly in calcific coronary disease. In OCT, you can always see dissections. So I think OCT is clearly better, but I think a key question is whether I should use OCT in a patient with an eGFR of 44. And we have data now from Japan. This is a Japanese registry that compared OCT and IVUS-guided PCI, close to 1,300 cases, and they propensity score matched patients on clinical presentation, CKD, diabetes, lesion characteristics, and looked at in-hospital and longer-term outcomes, both in terms of acute chronic kidney injury and longer chronic kidney injury. And you can see that overall, or in the CKD and non-CKD population, there was no significant difference in either acute kidney injury, so this is the OCT, this is the IVUS, or in the longer kidney injury. And in someone with only mild renal dysfunction, I think that the risk would be very low. In patients with much greater degrees of kidney dysfunction, I think it would be reasonable to use contrast-free OCT. So you could use that with saline OCT, and you get good pictures and probably better imaging than you would particularly with some of the IVUS probes, perhaps not with HD IVUS, but certainly Eagle Eye and so forth. So I think in conclusion, the only role of pressure wire in this case is to help you decide whether you should do the PCI. I think intravascular imaging will provide information regarding the mechanism of stent failure and whether PCI is still the best option, or if there's significant left main involvement, then make a decision about whether you do the PCI or refer the patient for surgery, particularly if the stent failure is not because of under expansion, but because of intimal hyperplasia. Its mechanism of in-stent restenosis, I think, is much better detected with OCT, and it will impact your treatment strategies, and result optimization is again better with OCT. This patient has mild renal dysfunction. This is not a contraindication to OCT. In most cases, you will only need 2 OCT runs. At most, this will add 20 to 30 contrast mils to your cases if you use contrast. If you're using saline, then it's irrelevant. We know that in cases of patients with mild renal dysfunction, literature suggests that if you increase the risk of contrast-induced nephropathy only when you increase the eGFR by 3.5-fold in mils of contrast. So in this case, this patient has an eGFR of around 45. That means that we can probably use around 140, 150 mils safely of contrast without increasing this patient's risk of CKD. Only 20 to 30 of those mils, if we do use contrast, will be will be due to the OCT. So in summary, I think that I would use pressure wire for this case to assess whether I would do the case, and then OCT for the rest of the case. I rest my case and hand back to the chairman, and thank you for inviting me to contribute.